Welcome to the Ambulatory Healthcare Today podcast, hosted by the NextGen Advisors. Accelerate your success with insights from a multidisciplinary team of healthcare experts as they discuss an array of topics. These timely discussions can help you better navigate the challenges of running your ambulatory care practice. Here is your host.
Hello, this is Graham Brown, Senior Vice President with NextGen Healthcare. Happy 2023 and welcome to our first episode of Ambulatory Care Today for the new year. Healthcare leaders often reflect at this time of year about what the coming 12 months will bring, what changes announced or passed legislatively in the last year are coming into effect, and how these forces and trends will impact the practice of medicine. In the now decade-long push to transition Medicare fee-for-service to beneficiaries into value-based care arrangements, the Centers for Medicare and Medicaid Services have continued to refine their accountable care organization performance programs with the aim of incenting provider practices to participate. The beginning of January also brings the start of a new calendar performance year for ACOs, so it's timely to discuss what innovations are occurring in value-based care and changes we know that 2023 will bring from a program perspective and the implications for ambulatory and hospital-based primary care practices. Today, I'm pleased to have two leaders from NextGen's partner in accountable care, Vytalize Health, joining me, co-founder and CEO Faris Gawi, and Dr. Amir Al-Najjar, co-founder and chief medical officer. Welcome, Faris and Amir.
Hey, Graham. Thank you.
Yeah,
thanks for having us.
Pleasure to be here. Thank you so much.
Happy New Year.
So Vytalize is one of the fastest growing provider-owned ACOs in the US, and you guys have some unique features and attributes, and I think it would be worthwhile for us to maybe begin there. Perhaps, Faris, you could start by talking a little bit about Vytalize and what makes your approach to accountable care unique.
Yeah, sure. Thanks again for having us, Graham. Vytalize Health works with primary care practices. We work with practices, small and large. We work with community health centers, as well as other ACOs, to basically help transition care to value-based care, right? So we act as a national convener for providers who are committed to quality, value, and managing the care of the Medicare fee-for-service population. And we partner with these practices and help convert them to value-based care because of all the value that is inherent in these programs, providing better patient access to care, better health outcomes, and be able to capture that value through these value-based care programs. So you'll hear more about it here from us today, but we work very closely with the practices to help them be successful. We meet practices where they are and help them on this journey to value-based care that we're really passionate about.
Amir, what Faris just said and just addressed kind of is critical here in terms of my view. Many providers have signed up to participate in accountable care organizations over the past decade, but many of them weren't ever provided kind of the guidance and support that's necessary to be successful. I've worked with lots of hospital and health systems that have set up an accountable care organization and they have a lot of employed physicians, which they just enroll into that ACO, but they don't always provide those providers with some of the background, the training, the resources that they need to be successful in accountable care. And so as a result, those ACOs, have a history of failing. Some of them just never achieve the types of savings that they are striving to do. They don't necessarily improve the quality or the outcomes for patients. And so the investments that they made practically aren't, that successful. So I'd be interested to get your perspective on how Vytalize is kind of different in terms of how you approach your participating practices and how you support them to be successful in a different manner.
Thanks, Graham. Completely agree. When we first started in this space, looking at different ACOs, a lot of it is very loose. You may have a webinar every 3 months and not a lot of guidance. And one of the things that we did at Vytalize is, we realized that it's a slightly different way of looking at the world, and it needs folks that really know it to break it down in bite-sized pieces for the practices. We understand a lot of our PCPs have a lot going on, and they may not have all the time in the world to spend reading hundreds of pages of, CMS regulations about new programs and initiatives. And what we've done within our model is to try to bring it to the practices and meet them where they are. So what makes Vytalize unique is every practice that joins Vytalize will have their own dedicated medical director. These are physicians trained in value-based health, experts in ACOs and value-based care across the board, and they meet with you one-on-one. It's not a webinar where you're with another 100 practices, you're listening to a lecture. It's one-on-one conversation to really understand what the pain points may be and what the strengths may be of a particular practice. And we work together sort of like as a consultant working with these practices to help solve one of these problems. The nice thing about healthcare is none of the problems are tremendous. There's just a lot of small problems. And we work closely with practices to see where they're at and coach them up to where they need to be and help with the blocking and tackling. There are a lot of different things that need to be done in order to make a practice successful in value-based care. You need some of the technology infrastructure. We've come across a lot of PCPs that don't always know where their patients are at. Oh, are they at this hospital or this location? By having the proper ADT feeds into the practice, letting practices, be aware of where their practices may be, that helps with things like transitions of care, which has been proven to improve outcomes, but isn't done a whole lot because of these gaps. So what we do is, we meet with the practice, meet them where they are, the pace that they're at, and try to work with them to solve it. Do they have a challenge around bringing certain patients in for annual wellness visits? Is it a challenge, as we said earlier, about the ADT feeds? Are they not sure who their patients are seeing from the specialty network, and if there may be better specialists that they could be working with? So a lot of that stuff requires the infrastructure that Vytalize is able to bring in. And in one of these one-on-one coaching sessions, doc to doc, able to formulate a plan and work together. So ultimately when people ask me, okay, well, I want to join Vytalize, what is the one thing I need in order to be successful? The one thing that we measure success is engagement. When practices meet us halfway and they engage with us and they're open to working and connecting, they all get better. It's practices that may have a lot going on are not able to meet us and engage, where typically, imagine if you don't change anything, why would the results change? So, that's the number one thing. So if a practice is willing to be open, engage with us, we're very confident they'll be successful in value-based care. And they'll be much happier in the process, because that's why a lot of us physicians went into medicine, is to provide value and not to provide services.
Can I add to that, Greg?
Yeah, please. Yeah, Ferris, go ahead and add.
Yeah, so just to add to what Dr. Aljar laid out here, we really took a hard look at all the moving pieces that need to happen to transition practices to value-based care. And one of the things that we did was align the financial incentives with those actions, right? So one of the the ACO programs is a really great program with tremendous potential. One of the challenges in it is that in a typical ACO, a practice would not see any financial upside or shared savings until 2 years later after they join. What we've done at Vytalize is we have monthly bonuses that the practices can earn for closing care gaps and taking the step-by-step that's needed to be successful in value-based care. So practices begin to feel the value day one, and we continue with them and help them maximize that.
So I appreciate you adding that element, Ferris, because that's a really unique attribute of the model that Vytalize has. And indeed, waiting 2 years for the performance year to close and then kind of guessing whether you're going to achieve shared savings or not, and waiting for CMS to reconcile that is a long wait. And one of the things that's really been a barrier to entry for a lot of small practices considering accountable care organizations. So Amir, maybe build out on what Ferris was just saying. Talk a little bit about what's involved for a practice in terms of earning those bonus payments. What are they doing on a day-to-day basis? And how does that get recognized in terms of the funding that Vytalize provides to them each year?
Absolutely. And one of the things that we're proud of at Vytalize is, we are physician-led. We, consider ourselves, we really listen to the physicians out there in terms of what is lacking. and exactly what Faris and you alluded to is, years of work for maybe a possible payout. I don't know about you, Graham, but if someone offered me a job and they said, maybe we'll pay you in 2 years, I'm probably not going to do that job too well. And that's what we were hearing from the marketplace is, did all this work, all these changes, nothing came out of it. So, being confident and bullish in our approach, we wanted to put our money where our mouth was. And, what we said is, if you do these things, and a lot of it, physicians already know they're good things, such as transitions of care, annual wellness visits, getting the quality metrics done, making sure patients are getting their colonoscopies, their mammograms, their flu shots, whatever else it may be, things that they're probably already doing, most of them, on some level or another. We reimburse for that. We as a Vytalize take a risk on practices and front that money before we even know the results of that year, what will happen, because we're so confident in our approach that this was what generates savings. But we need to be the one that's willing to take the risk and not put all the risk and the onus on the practices. And that's what we've done at Vytalize, is come up with sort of an approach onto things that improve care and reimburse for it. Another thing is, as we talked about earlier, we engage practices on a weekly, bi-weekly basis. We're asking a physician and their office manager to, meet with us, to touch base, to update them on things. We reimburse for that as well. Ultimately, we put ourselves in the position of the physician and said, what would be fair and what would be some things that wouldn't be fair that they wouldn't like. And we really work hard to be a very physician-centric model and an approach. And that's what we've developed. So if you're doing extra work to get things done, if you're taking time to spend with us, you're getting paid for that. And that is reimbursed. That is paid to you within the first month. So if you were to join us January of 24, by February, you'd be earning that. And even if that performance year as an ACO, we do not generate savings, practices keep it. Our practices are never at risk. Any money we give them is for them. And one of the things that we prided ourselves on is the money always flows from Vytalize to our PCPs. We're never asking PCPs to pay for things. We're always looking for ways to pay them. Because ultimately, they're the ones that are going to be able to make the biggest impact in value-based care.
Well, and I think you guys have demonstrated so far that indeed that model is working for you. You've been able to achieve shared savings in the out years by encouraging practices to do the right thing today and trust that those dollars will be achieved in the program. Let's shift a little bit in terms of how Vytalize supports your practices kind of with the most complex patients. So I know one of the things that you do is provide practices some insight as to who are the most complex, highest risk members, those that might be, not regularly getting primary care or not touching base with the practice. They might be, showing up in the emergency department when they, in fact, just need to go see their primary care doc. How do you approach practices and support them in that way?
One of the things, Graham, that might be worth mentioning is Vytalize started as a practice ourselves. So we started out by caring for our own Medicare patients. And, with Dr. El-Najjar's leadership, designed a care delivery model that was focused exclusively on that population. Right? And what was involved there was a very proactive approach to care, meeting patients where they are, whether at home remotely or at the practice, involving the family, looking at mental health and making sure that behavioral issues were addressed and access to care there was provided. Look at the social determinants of health to understand what else other than the clinical considerations may be going on with a patient. And that high touch care that we built for the high risk population is something that we were able to maintain and bring to our ACO practices. So to the extent that there are patients that have become very frail, maybe homebound, unable to come in and see their PCPs, we work with the PCPs very closely to enroll these patients in what we call our priority care program, which is a very kind of high-touch 360 care program that Vytalize delivers directly to patients in coordination with the PCPs. So, we found tremendous success with this program. Patients that may have fallen between the cracks are kind of picked up, and we make sure that they maintain that relationship with their PCPs while extending the doctor's office beyond the four walls of the practice into the home.
Graham, this program was actually built by the PCPs coming to us asking for this functionality. We provide practices with data and analytics around who are patients that may be at high risk to be brought in to be seen more proactively by the PCPs. But what we found is, on average, each practice had a couple of percent of patients that they, would tell us that, hey, they're homebound, they don't really come in, I don't do house calls. What do you want me to do about it? So what we've done is we've developed a home-based program called the Priority Care. We send nurse practitioners to do the home, full assessments, uh, get everything, we do a lot of social work there as well, SDOH work, it's, outside of normal just clinical medicine to make sure the patient is taken care of holistically. And, we work closely with our PCPs. It's not something that we silo off. Our NPs report to the primary care physicians. Our primary care physicians are able to earn revenue for that, for their time collaborating with our nurse practitioners. But the goal is to offer excellent care and not to leave anyone behind. And as we all know, there's a lot of stories about how folks just fall through the cracks in healthcare, and that's what we're really trying to avoid with our PCP partners.
Very neat. It sounds like it's a pretty successful model and one that you've been able to scale pretty effectively from your original roots in the Northeast to a nationwide program here. The final area that I think would be interesting for us to cover on today's episode is some changes that CMS made at the end of last year, right? Every year they go through this process of updating their physician fee schedule. And as they did that in November, they actually made a fair number of revisions to the ACO shared savings program. And I'd be interested to get some of your perspective in terms of those changes. What captured your attention? And do you think that the moves that CMS has put forward here to broaden and encourage the level of participation from primary care practices in accountable care, do you think that's going to move the needle? Do you think we're going to be successful in broadening the participation here overall?
I think so, Graham. I think that data is now clear that these programs work. They work in helping practices transition to value-based care, to providing better proactive care to patients. The results are better for patients, for utilization is down. And so I think the key messages that we take from these new regulations are that Medicare is absolutely committed to value-based care. They've said repeatedly they want 100% of providers to be in ACOs by 2030. We think it can happen actually earlier than that, given the trajectory. I think PCPs now recognize the value of these programs and that they're actually designed to help them, and they're kind of flocking towards them. I think the other thing that we see in Medicare's response is that they're listening, right? They're listening to the feedback. They're listening to suggestions for improvement from physicians and ACOs on gaps and areas where maybe the program was treating one cohort unfairly versus another. And I think that's really encouraging. They've been very, very close to the ACOs. We have a coordinator we meet with very regularly. They're listening to the constituents, and I think that's really encouraging. The final thing I would say is there's a clear commitment to health equity. This has been part of the conversation for the past few years, and there's an absolute clear commitment from Medicare that they want health equity to be at the forefront of this, and essentially encouraging practices and ACOs to go after areas that are hard, right? Not staying away from certain patient cohorts or things that may be difficult, but to actually run towards the problem and really address it head on. And this genuine belief that healthcare can play a role in improving society and bringing health equity. So we're really, really excited and encouraged by all the changes and think Medicare is really on the right track and it's doubling down on these programs. So we're excited about that.
So Amir, what else would you add to what Ferris just said in terms of CMS's plans for ACOs in the future?
Absolutely, Graham. So, with that theme, CMS is really encouraging folks to join these initiatives, and they're always looking for ways to make it more accessible to the average practice. One of the updates that they have for the 2023 performance year is they're changing how some of the quality metrics will be scored. So prior to 2022, it was, whatever your score was, that was a multiplier on, so if you had a 90% on quality score, that would be a multiplier of your total shared savings. In 2021, they changed it where it was if you met a certain threshold, which was 30% of all reporters, if you were above that threshold, you got the shared savings. If you were below it, you got nothing. What they're changing it for to make it easier is what they're saying is even if you don't hit that 30% threshold, rather than it being an all or nothing, you'll still get a part of savings. So this is all consistent with all the updates that they've made. They're trying to make it easier and more accessible. These programs work. I'm someone that's, not always, very bullish on governmental programs, but this is something that has worked, tremendous success. And frankly, as a physician, I couldn't think of a better initiative to improve outcomes. We as a society have been paying for services, fee for service. Guess what? We got a lot of services in this country. Now it's time to pay for value and outcomes and quality, which is what this program does. So hopefully we get a lot of value and quality moving forward.
Yeah, indeed. It does really feel like CMS has, to your point, Ferris, listened to the provider community on what's working in these programs, what's not, what are the barriers to entry, and really trying to kind of prime the pump to make it easier and less risky for practices to join an ACO. It feels like it's a pretty critical time for value-based care, and that the several years ahead as we approach 2030, we just got to keep at this and keep moving more and more practices into the mix here. So with that, I'd like to thank my guests, Dr. Amir Al-Najjar and Ferris Gawi from Vytalize Healthcare, for joining me today, sharing information with our listeners about their unique ACO model. If you'd like further details, you can visit nextgen.com or Vytalize.com, where you can learn about the NextGen and Vytalize partnership, as well as some of the details of how ACO enrollment for 2024 is available to primary care providers. Thank you also to our listeners for tuning in today. This is Graham Brown with NextGen Healthcare. Thank you and have a great day.
Thanks for listening to the Ambulatory Healthcare Today podcast, hosted by the NextGen Advisors. Never miss an episode by subscribing at nextgen.com/podcast. To see a list of products and services tailored for ambulatory care practices, visit nextgen.com.